Oops, there we go. Hi, everyone. Happy Wednesday. It's nice to see everyone this morning or this afternoon or this evening, wherever you are. My name's Anna. I'm one of the CP solvers based in the US in San Francisco. And I am very excited to discuss a case with you all today. I'm kind of doing some last minute pinch hitting. And so I am excited, but also nervous. And today we'll be looking for two folks to discuss a case with me. And then also somebody to present a case. Thank you, Kiara, for looking for cases for us in the chat. So if you have anything, even if you feel like it's a rough draft and something that's like not super well ironed out, that's a very authentic learning experience still. And so we would welcome that. But as we're kind of maybe waiting for people to step forward to present, to see if there's a case or people to volunteer to discuss, I wanted to wish so many of the folks who are here probably a happy graduation. I was talking with Kiara before this started, and Kiara is now newly Dr. Camacho, and so congratulations to Kiara. And then to anybody else who's here today who's recently graduated. Super, super exciting. Being a medical provider, a healthcare provider in general is just one of the greatest privileges. It's so fun to be in a field where you're a lifelong learner, and then just such a privilege and so special to get to take care of people during a really vulnerable time of their life when they're sick. And when they're healthy too, although I don't do much primary care, but when they're healthy too, I'm sure that that's also very rewarding. But congratulations to our recent graduates. Anyways, yes, and Dr. Camacho will be doing our teaching points. And we're still looking for some folks to volunteer to discuss or present, whether you're a first timer or you've done it several times before we would welcome you into the warm seat. I was reflecting recently, it's been maybe a little over a year that I've been involved in the CP solvers in like the VMR kind of space. And I was reflecting recently on kind of how nervous I was the first several times that I discussed. And it really is something that just becomes easier over time in terms of kind of that like inertia you feel like you need to overcome to enter the space. But it also, it's something that becomes like that much more rewarding. I feel like as I've kind of done it more and more and feel less nervous, my ability to like retain the information that I learn from all of you all in the chat is much, much better because I don't have as many of the nerves in the way. So it's a wonderful, wonderful learning environment. I see Amanda. Yes, we would love an old and simple case. That sounds perfect. Thank you for volunteering. Still looking for two people to discuss with. So if you're feeling brave, then we would love to have you. I'll especially need a lot of help as I feel like I haven't been doing so much VMR recently. Maybe while we are waiting for some folks to volunteer to discuss, Amanda, if you wanted to unmute yourself and maybe just tell us a little bit about yourself. outside of the learning environment, kind of the things you like to do, where you're tuning in from, and that type of thing.
Hi everyone, I am Amanda. I am from Brazil and I am 23 years old and I am a fourth year medical student and I love presenting case. I think everyone knows here and I'm so excited. It's a simple case, okay? Not big, too much, no.
That sounds awesome. Thank you so much, Amanda. I also want to emphasize that there is so much goodness to be learned from just straightforward cases. Sometimes the cases that don't have all the frills and the crazy diagnoses, there's so much clinical reasoning to be done from cases like that. So I really appreciate you bringing this case to us. I'm excited to learn from you. And then it looks like Sophia has volunteered to discuss. Thank you so much, Sophia. While you maybe come off of mute and similarly introduce yourself, we'll wait for another person to volunteer to hopefully discuss with us. But Sophia, feel free to tell us a little bit about yourself.
Okay, hi everyone. My name is Sophia. I'm from Brazil too, but now I'm in Russia, finishing my second year of medical school. And was a long time that I'm not being here because the university was consuming my time, but I'm so happy to be here again.
We're really happy to have you back. Thanks so much, Sophia. Yes, Amanda, there's a lot of good Brazilian energy here. Oh, and happy belated birthday, Sophia from Drew.
Thank you.
Cool. Well, really excited. This is going to be an awesome case. And then Drew is also bravely volunteering. Drew, do you want to come off of mute and introduce yourself before we jump into the first aliquot with Amanda?
Sure. So hi everyone. I'm Drew. I am a soon-to-be PGY1 at Western Michigan University in MedPeds. And just recently moved out of my apartment in Richmond that I have spent the last 5 years in, so all through med school, and hopefully going to be moving to Michigan within the next week or so. But until then, I'm up in New England with family and excited for this case.
Awesome. That sounds great. Well, thank you again for joining us, despite all of the moving pieces that are happening in your life right now, Drew. I figured that we could structure kind of the way that we talk through the case, at least the way Erin does it for neuro cases, where maybe we can have both Drew and Sophia kind of comment on each aliquot depending on how we're doing for timing. We will walk through this oldie but a goodie together. Does that sound okay with everyone? Cool. All right. Well, Amanda, again, thank you so much for presenting this case to us. And we will let you take it away.
So let's start. Drew, this case is for you because it's an 8-year-old male comes to the ED with his mother complaining of abdominal pain.
Oh, fun, a pediatrics case. All right, I guess I can start then. So the differential for abdominal pain in pediatrics is honestly quite similar to that in adults. Although there are some, and especially since this is an older child, there would be a bigger differential and a relatively different differential in a neonate or a toddler. But this child's old enough that we could probably consider a lot of things that would affect adults, with the exception of maybe gallbladder issues. So for abdominal pain, I'd like to first off mention Carol Lau, one of the CP Solvers team, and her abdominal pain thought train, where most of the differentials of abdominal pain are going to require imaging to be able to actually figure out what the cause is. But we can make a little bit of progress in developing the differential with history, in ruling out a couple of the differentials with a physical exam. So for instance, herpes zoster, if we see a rash, on a dermatomal rash on the abdomen, then we can easily explain the abdominal pain as more extra abdominal pain due to herpes zoster. Given that this patient, I assume, is probably in Brazil, so I don't know how common vaccination against varicella or chickenpox is. But here in the US, it would be very unlikely for zoster to present this young. Hernias definitely could be on the differential, and especially for a young child, an inguinal hernia is definitely on the list. And then in terms of labs and imaging, if this patient is coming in on their first presentation and we find hyperglycemia and acidosis, we could think of DKA, or diabetic ketoacidosis, as one of the differentials. Pancreatitis is also on the differential, but probably less likely in this patient unless he got into something. So with that, other than that, I'm interested to see the rest of the history to see if we can get further differentials. I'm interested to see the physical exam if we can get anything further on that front. And then the big test is going to be imaging. In an 8-year-old patient, it's likely going to be ultrasound first and then CT as a secondary imaging modality. But we as clinicians, and especially if there are any pediatricians on the call, don't be loath to do a CT if you believe that it is necessary. And if you believe that less invasive and less radiation inducing imaging modalities will not give you the answer.
Those are some amazing pearls. Thank you so much, Drew. I also want to say I'm so happy I'm discussing a pediatrics case with you and Sophia, both you going in to pediatrics as part of your training, and then Sophia, I'm not sure what you're going into, but at least you're learning about pediatrics right now. My heart sunk when I heard it was an 8-year-old child, but at least it's not like in the realm of infanthood. Sophia, I'm wondering if you have what are some of the questions that you're thinking about wanting to learn from the history for this 8-year-old boy coming into the emergency department with abdominal pain?
So I think the first question that I will ask is if you had any trauma previously, like the trauma can develop the abdominal pain. If this abdominal pain starts after any specific food or drink that the child can eat or drink, because it can be any kind of infection or a virus infection, like we don't know the complete history yet. I maybe ask if this abdominal pain starts now, or if the child is complaining about abdominal pain for several weeks or months. I maybe ask about family history, if there is anything that we can have to help. And I probably ask if the abdominal pain is causing any change in the bowel movement, like if the patient is having diarrhea or I don't know, constipation, something like that.
Yeah, I agree with you, Sophia. I feel like so abdominal pain can either be such a benign thing or can be such a serious thing. And I think getting a sense of these questions from the history will be so important, and asking about those symptoms of nausea, vomiting, diarrhea, constipation will be really helpful in kind of whether this is like a luminal process, something in the GI tract, versus if we should be thinking about other kind of visceral organs within the abdominal cavity that could also cause abdominal pain. And then I loved, Drew, how you're bringing up some other systems that we can think of. So like the GU system. So things like, if somebody has a UTI, or you brought up hernias as well. I think those would be really important. And then even getting into some of like the imaging negative abdominal pains with ketoacidosis as another cause of abdominal pain. And so I'm really curious to hear about kind of further history, and then also examine the patient to figure out if there's like a specific quadrant that might help us localize the abdominal pain a little bit better. And then also getting a sense of their vitals and maybe risk factors for infectious etiologies and whatnot, and asking about food history as well. I really don't have anything else to add on top of all of the information you already had mentioned. So maybe we can turn it back over to Amanda for a little bit more history.
So let's continue. It's a great discussion. And the kid reports diffuse pain that he has been worsening for 2 days, associations with polypsia and polyuria. Complained 2 episodes of vomiting last night. No fever or diarrhea, none weight loss, none past medical history or meds, none allergies. Father and mother are healthy, and his grandmother has diabetes.
Amazing. And then are there any medications or health-related behaviors to kind of fill out the bottom left-hand bucket to think about?
No, not important or relevant.
Okay, wonderful. So maybe Sophia, we can start with you. We learned about a couple of new symptoms the patient is having, and I'm wondering if this helps kind of frame your the way that you're thinking about the case so far.
I don't know if, I'm not sure, but I think maybe a diabetes, hereditary diabetes in the child, because he complains about polydyspepsia and polyuria, and because of the grandmother has diabetes. So I think we need more labs results to make sure this part. But I said about infection, but the child not have diarrhea, constipation, or weight loss or fever. So I will take out this part. But I'm thinking about diabetes, but I'm not sure.
Absolutely. It sounds like those things are ringing a very specific bell in your head for like a kind of total constellation of symptoms. And I agree with you. It's certainly very suspicious to me. And to help us, sometimes when I find myself, like if I'm admitting a patient and I find myself, I'm like, oh, all these like symptoms are coming together and this is like the perfect triad. I like need to fight extra hard to not fall into these kind of like these traps where I might forget about the symptoms in isolation and kind of just harness on the presence of them altogether. Drew, do you have any other, are there any other kind of things that you think about, and you maybe wanting to think about these symptoms still as separate entities, and kind of what your differential might be for somebody who's just coming in with polyuria and polydipsia maybe?
Yeah. The polydipsia and polyuria kind of, at least common things being common, it defaults my brain to considering diabetes and specifically DKA when we consider abdominal pain. But at this point, the one weird thing is that this boy does not have weight loss, and usually you would expect, if you have someone with type 1 diabetes, especially, to have weight loss because they are insulinopenic, and also that their polydipsia, polyuria, and all of their symptoms would have lasted at least a decent amount longer, before the abdominal pain and the fulminant presentation of DKA. At this point, I'd probably want to see an exam, and because polydipsia, polyuria could also easily just be patient is only able to take in liquids and not able to take in solid food, and he could have something like an appendicitis or something like that. The other thing that we do need to know, if this is DKA, is what is causing it. DKA almost always has a trigger of some kind, whether it be an infection, some sort of stress response to like surgery or something like that, a lack of insulin. There is a mnemonic known as the Five Eyes of Dka that basically tells what are the triggering events that could lead to an episode of DKA. Trying to think. Oh, myocardial infarction could also be one, but unless we're dealing with a case of Kawasaki disease, he doesn't have. It's highly unlikely that this kid would have myocardial infarction. Or unless we were dealing with like one of the cases that was presented a couple of weeks ago, a patient who has familial hypercholesterolemia and he already has the arteries of a 60-year-old. At this point, the most likely things that we could consider if this is DKA would most likely be infection or just florid lack of insulin. Oh, and also for insemination as well, because pregnancy can be a cause of DKA, but we don't have to worry about that in this patient, unless this patient is a trans man and was assigned female at birth and still has uterus and ovaries. So with that, waiting to see what the physical exam reveals.
That sounds awesome. Thank you for stretching us and kind of that exercise of just like pushing, like what could we be missing? What could we be missing is such like an important habit to get into to make sure that we don't anchor too early. And the learning about the 5 eyes for me was a new mnemonic. I haven't heard of that. So it sounds like things that we're wanting to kind of evaluate for. So I heard infection, I heard ischemia, insulin deficiency, insemination, like pregnancy for somebody who has the ability to get pregnant. And then what's the other one that I'm missing?
Ingestions. I forgot about ingestions. Yeah. So
okay.
I think like cocaine, I think is one of the big.
Okay, wonderful. That's a great teaching point. Thanks for telling us that. So I similarly was trying to like go down the pathway of how can I separate this polydipsia and polyuria from the patient's abdominal pain? Like what can I think about that's not DKA? And still thinking about like the polydipsia and polyuria separately. I was just like thinking of in my head, I'm like, okay, what makes people pee a lot? And then maybe the polydipsia comes from somebody who's just like peeing a lot and is trying to take in enough liquid to compensate. And so when people have polyuria, we define that as greater than 3 liters a day, at least in adults. I don't know if that's different for children, but there's kind of 2 reasons why people would pee a lot. One is that they're trying to get rid of water, and the other is that they're trying to get rid of some type of solute. And so when we think about somebody who's diuresing water, this is where we start to think about the diabetes insipidus, so either a central cause or a nephrogenic cause. Could the nephrogenic cause, could there be something like on the kidneys for some reason that's causing diabetes insipidus, causing abdominal pain, also leading to this? In the central cause, could they be having, some nausea and abdominal pain associated with that from some type of central lesion? And then diabetes insipidus, possibly, versus this being primary polydipsia, which is the other reason that we have polyuria with water diuresis. And then in the other bucket, we can think about people like needing to excrete certain solutes. So this is where the polyuria from DKA comes from, is that you have such a huge kind of glucose load in your body that you're excreting glucose, which pulls water with it. And so you have solute diuresis from that. And then the other kind of 2 solutes that I think of are sodium that we can excrete. So this is seen very often in the hospital, somebody who's given like a ton of normal saline and like just has a lot of like intravascular volume expansion will then develop polyuria in the setting of needing to excrete all of that sodium. And then also for patients who have some type of intracranial pathology and they're given a bunch of mannitol, that is also an effective osm and will pull water into the tubule, resulting in polyuria. So that's how I kind of like frame polyuria. You're either excreting water or you're either excreting solute. I think still to tie the case nicely together, I'm most suspicious about something like DKA. And so I love that we're thinking our steps of history, even before we move on to the exam, would be asking about all of these precipitants that Dhruv had taught us about. And especially if the patient doesn't have a history of diabetes. It sounds like we learned about the grandmother having diabetes. I don't actually know too much about the kind of the family history of type 1 diabetes, which is maybe something we'd be concerned about for such a young patient, how strong that is, but maybe learning about what type of diabetes this patient's grandmother has would be a helpful step. I don't think that I had any other thoughts. I thought that you all did a really great job of kind of pushing how we're thinking about this case. And I think the exam indeed will be really helpful. And maybe we can turn it back to you, Amanda, to tell us a little bit more.
So his vitals is heart rate is 108 and respiratory rate is 35. His BP is 10/8 and his stats is 89%. And he's afebrile on the exam. In Jan, he is oriented, mucous membranes look sick, HAANT without change, cardiovascular are normal, and respiratory is tachypneic, normal breath sounds without cracklers or wheezing, and abdominal is a flat abdomen, decreased bile signs, diffuse pain on deep palpations, not rebound tenders. Without alterations, it's that. Neuro is okay.
And then were there any other things from the exam that we don't have written down?
As is that some no, I say everything. I said.
Perfect. All right. And then how many aliquots do we have left after this one?
We have the labs and the final diagnosis.
Perfect. All right. Well, let's go through the physical exam then together. Sophia, maybe since you started us off last time, we can have Drew take us through at least his thoughts about the patient's vital signs, especially since he'll be able to interpret the heart rate and blood pressure through a pediatric lens, which I appreciate. Then we can have you take it away for the rest of the exam. So Drew, start us off.
So I guess I should just note that for any patients who are above the age of 13, even though we may still classify them as pediatric, their vital signs are actually, you can basically just use adult vital sign cutoffs for them. For an 8-year-old, they have a little bit more variability, but for this patient in particular, that resp rate is high and that heart rate is also pretty high. The resp rate being 35 is actually characteristic if this patient has DKA of something known as Kussmaul respirations, which basically means that the patient is breathing very hard, very fast, basically trying to blow off as much CO2 as they can in order to keep their blood from going way too acidic. And the SATs, those SATs are a little bit low. Normally for a kid, you would expect their SATs to be like in the high 90s, even if they were in DKA. But this kid's pretty sick. And I would imagine that the SATs could also be due to the fact that it may be it could just be that the pulse ox is not calibrated right, or another reason, but it's low for a kid of this age. Otherwise, not much else, and I think we can just move on to the rest of the physical exam. So, Sophia, you're up.
Okay, so about the vitals, I don't know what to say because it's a child and I'm not learning yet in the university. But about the dry mucous membrane, I know is one of the symptoms of DKA, like the dry of the skin, the dry of the mucus. So can be one of the signs to us to detect this disease. And the diffuse pain on deep palpation. I don't know what I can say. I would like a help because I don't know how to explain. I know it is not normal to have this diffuse pain on deep palpation, but I don't know how to explain this.
I don't know how to explain the abdominal pain either. We happen to have a case that we presented in our morning report earlier this week. And it's my understanding the abdominal pain is driven from the patient's underlying metabolic acidosis, as we see this type of abdominal pain with other causes of ketoacidosis, such as starvation ketoacidosis, alcoholic ketoacidosis as well. So it's not specific to DKA. I don't know why it happens, however. One thing that I learned, like a pearl that I can share before I have a couple more questions for you all, is that very often when patients present with ketoacidosis to the emergency department, they end up getting their abdomen imaged despite having very, classic presentation for something like diabetic ketoacidosis and whatnot. And so we were asking some of the attendings on our call if they, have like an approach to kind of risk stratify who does and who doesn't need abdominal imaging, because we are worried about there could maybe be infectious causes that we could see on imaging that could trigger diabetic ketoacidosis. And one of the pearls that I learned was that because this is driven by, the abdominal pain is driven by the metabolic acidosis, we can correct a metabolic acidosis pretty quickly with therapies for a patient in DKA. And so you could give yourself, 4 hours of appropriate treatment, correction of an underlying metabolic acidosis. And if the abdominal pain persists, perhaps it makes you, and the tenderness persists, perhaps it makes you think a little bit more about getting imaging. So that's something that I learned just earlier this week. But why the abdominal pain exists, I do not know, but not specific to DKA, just metabolic acidosis more broadly. If anybody does know, I welcome them to either unmute or write in the chat to let us know. Were there anything, Sophia, in particular from the exam that you'd be paying like extra special attention to, or something you thought you'd see on exam that you don't see?
So I think the glucose level is the main point to us to define the diabetes. I think about the sodium levels too, because of the acidosis. And for me, the main point is the glucose level, and the AST and ALT maybe can help us to identify the problem.
Absolutely. I think that those are all great things to be looking out for. A few more questions that I had for you all. So when I am similarly concerned about the patient's low oxygen saturation with a very elevated respiratory rate. And it sounds like they have normal breath sounds without crackles. How do we think about when we have like a normal pulmonary exam, somebody who's in obvious respiratory distress, but they're also like hypoxic? Does that help kind of frame at all how we think about their underlying pulmonary process?
If it's DKA, then I would think that the lungs would be normal. It may just be that it's that because the patient is breathing so fast that they're not getting as much oxygen in. But again, I guess it's more like it's low enough to trigger to go red on the EMR. But if you treat the underlying issue, then it'll probably go, then the kid's probably going to start breathing more normally, and their oxygen saturation is probably going to go back up. The pulmonary exam actually is quite reassuring on that front.
Absolutely. And we know that the reason why people develop the Kussmaul's respirations is so that they're trying to compensate for how the metabolic acidosis that they have. And so they're trying to blow off as much CO2 from their lungs as possible. When I see somebody who's hypoxic with a normal respiratory exam, that kind of the first things that go through my mind are, does this patient have a PE? That's something that I think about a lot because I take care of adult patients. And then the other kind of thing that I wonder about is exactly, Drew, you were getting at some of these things earlier. Is there something wrong with like the pulse ox, the way it's picking up the patient's I actually don't even know if it's like arterial venous, like wave, like the blood supply there, but is there a problem with like reading that versus is the body in just such a state of metabolic activity that the cells just can't keep up? And that there's there's simply like a supply demand mismatch, and the problem is not in the lungs, like at the site of gas exchange. It's just like the body being too metabolically active. So we see this like sometimes in the setting of really, really severe sepsis. But I'm curious as to what the patient's arterial blood gas will show us with their PaO2. What are some of the labs that you all, maybe Sophia, you can answer first. You had mentioned a couple, and then Drew as well. What are some of the labs that you all are going to want to get for this patient and other workup?
It's for me first.
Mm-hmm.
Again, about the labs, I said about the glucose levels the sodium levels, AST, ALT levels. Maybe we can find something. Maybe the white blood cell levels too, we can try to see, because we are saying about diabetes, but we are not sure. It can be an infection, can be other things too. So for me, this is the point that I saw in the left.
So standard rule in pediatrics, and actually, to be quite frank, this should be a standard rule in adult medicine too. Do not stick if you are not going to use the blood for something that will help you with your diagnosis. So for this patient, a point of care glucose is probably going to be extremely important to get, as Sophia mentioned before. I would get a basic metabolic panel, and I would also get a venous blood gas. It's one stick for both in there, and the venous blood gas is far easier to get than an arterial blood gas, which the only thing that would be beneficial on an arterial blood gas is getting a more accurate PaO2. But all of the rest of the values on an arterial blood gas you can easily get from a VBG, and they're not that far off. Again, the only reason that you'd be getting an ABG is if you wanted to calculate an AA gradient. For other labs, I guess the only other thing that I would think of, probably would not get a hepatic panel on this patient. Maybe a CBC to check if there's an elevated white count to see if there's an infection. And if we're getting blood for a BMP, then we can just add that on. And then the other thing that we probably should get, we could, I guess, send this off now, but the results probably are not going to be back, especially if this patient on their point of care glucose has a glucose that's sky high, would be there's a diabetes autoantibody panel. So anti-GAD65 antibody, anti-zinc transporter antibody, anti-insulin antibody, and anti-islet cell antibodies. Get all of those and ensure that well, if they're positive, then boom, instant diagnosis of type 1 diabetes. If they're not, and if this patient is in DKA, it's still likely type 1. At the very least, this patient is going to have to be on lifelong insulin. So those are probably the tests that I would get. In terms of imaging, I would defer doing any imaging until unless the labs say something that unless the labs do not indicate that we have DKA, and then I'd go after imaging, and I'd probably start with an ultrasound first, and then CT.
Thank you both for sharing your thoughts. And I think it's so important that you both had mentioned that, like, we don't, especially for a pediatric patient, we don't want to poke somebody and make someone more uncomfortable than we need to. The one caveat I will say when I think about that question is DKA a life-threatening diagnosis?
Yes.
Yes. DKA has a very high mortality rate. And this is someone where we are going to be checking labs on them probably on an every 4-hour period. And so I love and agree with the sentiment that yes, less is more almost all the time. But this is something that presents quickly, and it can be deadly. And so this is a patient where I think I'm going to want to be very complete with my workup up front and setting a broad infectious workup, blood cultures. I'm going to get a chest x-ray because I don't trust my own pulmonary exam enough to be like, I didn't hear a crackle there. And so to make sure we don't need to be treating them with antibiotics to cover for a pneumonia in case that was their underlying trigger, trying to get urine studies to look to see if there's evidence of a UTI, which is very commonly in the world of adult medicine. UTIs and DKA go in hand all the time. And then I love the idea that first we're still anchoring on DKA. And Amanda hasn't told us no yet, so maybe that's a sign that we're on the right track. But once we have the diagnosis of DKA, I love your idea, Drew, of being proactive and sending those antibody tests for the patient in-house before they establish care with somebody in the outpatient world. I think that that's a great idea. And then going back to, yes, a point of care blood glucose, absolutely. But to re-emphasize that diabetic ketoacidosis, the hallmark of the disease is really the metabolic disarray that makes that is behind like the high mortality rate. And that there's really cellular dysfunction with the degree of metabolic acidosis and then some of the other electrolyte abnormalities that we see. And so while getting a point of care blood glucose, it might read something elevated, like between 200 and 300 or so. It's really the acidosis that I'm most worried about for this patient. And so we'll be wanting to trend those labs closely over time as we kind of initiate our interventions. So now that we all have talked a whole bunch, let's turn it back over to Amanda. Maybe she'll tell us that we're all wrong and that this patient indeed has something very obscure and not DKA, but I'm curious to hear.
Whoa, it's very great discussion. So in the hematology, we have white blood cells, 12,000. The bands is 3%, neutrophils 7%, and lymphocytes 20%. Hemoglobin is 12.2, MVC is 81.7, and MCH 28.5, and RBC is 4.95. Platelets is 200,000. In chemistry, you have sodium 131, potassium 5.5, chloride 95, urea 17. Creatinine 1.3, glucose is 595. Venous pH is 7.9, PO2 is 56, PCO2 is 19, and bicarbonated is 9. And we have the exam gives us the diagnosis. I can say?
Let us discuss those labs to make sure that we're all thinking about this the same.
Okay.
Were there any other studies that were sent before the final diagnosis was revealed? It sounds like no other labs. Okay, so Sophia, what is this affirming for you in your mind? Are there things that are expected, unexpected?
So the glucose level, I will start from glucose because it's the main point. So the glucose level was expected to be high. But for me, the white blood cells, they are high, like a little high. So was unexpected for me. I don't know if it's common for DKA, but for me it's unexpected because I understand that white blood cells, lymphocytes, and the neutrophils, they go to infection, to bacterial, virus, any infection. So DKA is not infection. So for me, it was unexpected, these labs, but the rest I was expecting.
Yeah, I agree with you. Drew, how do you make sense of the elevated white blood cell count?
For me, it's probably it probably is an infection that that tipped this patient over into DKA. The one thing actually that I do want to comment on is the potassium of 5.5. That's high, but if this patient has an insulin deficiency, once you put this patient on an insulin drip, that potassium is going to go down because the potassium is going to get shunted into cells. If the patient has a normal potassium while they're on an insulin drip, you should be supplementing their fluids with potassium because they can develop hypokalemia if they are if they don't have potassium on board. The sodium is a little low, but again, given the fact that the glucose is 595, that's actually normal, and that's pseudo hyponatremia. Creatinine of 1.3, probably because the patient is massively dehydrated. Yeah, at this point in terms of management for this patient, fluids, I'd probably start this patient on lactated ringers. I don't want to give them a hyperchloremic metabolic acidosis, not a non-GAP metabolic acidosis, in addition to the DKA that they already have. Although normal saline is still the standard fluid that that people use in DKA. An insulin drip, and then and basically the insulin drip is for up until the anion gap closes. And let me actually calculate that anion gap.
I don't think we have a bicarb to calculate it from, but my calculation is that it would be high, because I think we actually just get to like 36 and then minus the bicarb.
Yeah.
Probably not.
Yeah, if the bicarb is even normal, it would be like at least it would be at least like 16 or so. So yeah, so essentially this patient should be on an insulin 9. Okay. Yeah. So the patient has an anion gap of 27. We run the insulin drip until the gap closes to normal, which would be anywhere between 8 to 12. And then we start the patient, typically even while they're still on the insulin drip, like maybe a couple of hours before, we start them on long-acting insulin, like insulin glargine or insulin detamir. Then we get them onto a basal bolus insulin regimen. And for this patient, I know that they're probably, I would assume that in Brazil, forgive me if I'm saying something completely wrong and these tests are sent out, but usually in the US, the next step again would be, as I had mentioned before, to send out the diabetes autoantibodies to confirm that this is type 1 diabetes. But most likely the management is still going to be the same. This patient is going to require lifelong insulin.
That was awesome, Sophia and Drew. Thank you so much. And I agree with you. I think a lot of this is as I expected. And then the only thing that I'll add is that when I'm interpreting the white blood cell count, I was saying it kind of as a trick question, because anytime the body is physiologically stressed, for which DKA is a very, very stressful thing for the body to go through, you can have an elevated white blood cell count. And so what I would do to interpret this is I would send my broad infectious differential, like I mentioned. Oftentimes they're treated empirically with antibiotics if there's something localizing from one of those things, and kind of depending on their overall level of illness. And then we can kind of de-escalate as either we have no growth from cultures or like something to kind of tailor towards. And so it was a little bit of a trick question, but not all elevated white blood cell counts will come from infection, just general stress on the body, for which DKA is a cause, infection is a cause, amongst other things. And then a lot of these metabolic derangements, like we talked about, are as expected in DKA. And I think to really solidify the diagnosis, I would love to see a beta hydroxybutyrate sent from the serum. It's not necessarily something we can track over time, but to actually see that their body is in ketoacidosis as the driver of their elevated anion gap would really seal the deal for me. And then, like you had mentioned, Drew, a couple of times now, sending out those autoantibodies. And to quickly run through, I thought you did a beautiful job of walking us through the kind of management of DKA, but to re-emphasize a couple of things. Life-threatening diagnosis needs to be treated quickly. And so really I think about it for like correcting the underlying metabolic disorder for which the patient's in like profound insulin deficiency as the cause of their metabolic disarray. And so starting the insulin drip, oftentimes fluid resuscitation is another component, and then adding potassium to the fluid, like Drew had mentioned, because their potassium, while on the higher side right now, will rapidly, as it shifted intracellularly, come down, and they're still whole body potassium deplete. And then other things that we'll want to kind of keep track of as we're doing our interventions are the patient's K, phos, and calcium over time, all of which oftentimes need to be very aggressively repleted. And phos is one of those tricky things where these patients often are hypophosphatemic. And then similarly, as you're giving the cells insulin and then they start using phosphorus as part of the ATP cycle within cells, they can become very hypophosphatemic, which in and of itself can be life-threatening. And so keeping track of that over time, because it's not on BMPs and you have to order that separately. And then the decision to kind of switch over to the basal bolus regimen, but having that period of overlap of being on the drip and then switching over to the basal bolus regimen is really important to make sure their gap doesn't reopen. And then putting somebody back on an insulin drip is never a failure. I feel like I have like a 50% chance of like not having to put somebody back on an insulin drip, but if you need to do it, you need to save their life. And so don't be afraid to do that if their gap happens to reopen. But that was an awesome case. Amanda, take us home and tell us what you all did for this patient, and then we can turn it over to Chiara for some teaching points.
Oh, Anna, just wanted to make another quick mention.
Yep.
And I posted this in the chat, but as was posted on the first episode of the Things We Do for No Reason episodes that the curbsiders and cribsiders do, one of the you had mentioned blood cultures as something that would be put for this patient. We can actually do what instead of having to do like a 48-hour rule out, we can do 36-hour rule out for infection, because most blood cultures, if they are going to pop positive, will pop positive within the first 24 to 36 hours or so.
Thank you for sharing that. That's awesome. I didn't know that. All right, Amanda, back to you.
So the exam that gives us the diagnostics is a urine exam, and it's normal. Just two elements change, that are glucose 3 cruces and ketone 3 cruces. And we have the final diagnosis, DKA, ketoacidosis diabetes, or diabetes ketoacidosis. I some curious to say, and I saw Val ask in the chat. And in childhood, the diagnosis of diabetes usually comes after a ketoacidosis crisis, and is the leading of cause of morbidity and mortality in children with type 1 diabetes. And that means many etiologies like infection, irregular use of insulin, alcohol. So it's a disease that requires early diagnostics and early treatment.
Yeah, thank you for highlighting that, Amanda, and Valeria, for that statistic in the chat. It is a diagnosis at such a young age often, and is a very challenging disease to treat over the course of somebody's life. As we learned that, you really are insulin dependent for life. Yeah, a lot of complications to look out for as folks get older as well. That was expertly presented case. Indeed straightforward, but as you can tell, so much to learn from still. DK is a great kind of at least a very interesting disease to think about clinically. Let's turn it over to Chiara to go through some of our teaching points. And thanks so much again, Amanda, Sophia, and Drew. That was an awesome discussion.
Thank you, Amanda, for presenting this case. It was amazing, as your last case that you presented, amazing too. So we started with a little male, 8 years old, with abdominal pain. And something very interesting and very important that Drew said to us is that most complaints of abdominal pain will require imaging. However, we can help narrowing this diagnosis with the HPI, for example, the time course, history, if this patient had previous vaccination or not, traumas, thinking about an example in GI bleeding, food and contacts, and we can also narrow the diagnosis with physical exam, right? Because there is probably abdominal pain plus many other symptoms. Also important in PIDs is that we need to radiate a little, not we have to try to radiate less. Some other concerns, if there is a pediatric patient, we have to think about hernias, especially inguinal. There can also be a risk for pancreatitis. For example, if there was some kind of trauma in this kid, mumps is a cause of pancreatitis, but this is very rare now that there is vaccination everywhere. And it's important that there are some image negative diseases with abdominal pain that we are not able to see at CT or any scan, right? So here we can have metabolic diseases like ketoacidosis, like in this case, medications, toxins, or any functional diseases and others. And then there was a little concern that this patient was not having a debut of type 1 diabetes, or like in this case, like ketoacidosis, because this patient was not having weight loss, and the polyuria and polydipsia that's on his presentation wasn't long term. But we also need to think about some triggers for DKA, like in this case, Drew mentioned the 5 A's, that is infections, lack of insulin, ischemia, insemination or pregnancy, or ingestions. And then Anna told us a very beautiful approach for polyuria, where there is mainly two things. You are excreting too much water or you are excreting solids. If you're excreting too much water, you can think first of primary polydipsia because you're taking excessive water, or maybe diabetes insipidus that can be central because of a decrease in ADH secretion, or maybe nephrogenic, maybe due to a resistance ADH. And the other part of the equation is that you can have polyuria because you're excreting too much solids. And why this can be causing? Because maybe you have DKA, you have increased sodium due to, or maybe you have some intracranial pathology and you are given mannitol and you're excreting solids. And another pearl that I find very important is that when we have abdominal pain, you always have to think about DKA, because there's, especially you have a highly suspicious of metabolic causes. So if you're suspecting a DKA, try to correct it as soon as you can, because it has a high mortality rate. And if after you are correcting it, if it persists, there is an intention and need to take an image. This is important because first you treat the most high mortality rate causes, and you also decrease the number of scans or images for your patient. Then after we were listening to Amanda's presentation, the question is important as of how we can move forward. So we have to ask some labs. In this case, we have to ask for glucose, urine studies, basic metabolic panels, venous blood gases, and white blood count, because one of the most important triggers for DKA is an infection, in this case urinary or pulmonic infections. After that, Drew strategically asked for some antibodies for type 1 diabetes that they take longer, but it's important to ask for them. And I think that the most important part of DKA is the management, because it's, as I mentioned before, it has a high mortality rate, so you have to treat it immediately. And first you have to check potassium, because if it's normal or low, you can supply potassium fluids to replete those intracellular stores along with insulin that you are going to give to the patient. Also, you have to check FOS, because you have to check it before giving insulin. So yes, ask for them and you will have it. And then you have replete these patients with IV fluids, because in DKA, or even, and of course in an hyperosmolar state, in other cases, you have like fluid depletion, so you have to replete them. Most commonly with Ringer lactate. Also, you have to start your insulin drip until the normal gap, and then when you normalize the gap, you can start with long-acting insulin. However, if you have again an abnormal gap, you can start again with an insulin drip. Also, you can start empiric antibiotic, especially if the trigger of this DKA is an infection, and you can de-escalate if there is no growth in cultures. And Drew mentioned that most commonly bacteria will grow in the first 24 hours, so you can check it the first 24 hours on the next 48, and if there is no growth, you can start de-escalating them. And if there is no growth like in more hours, the probably cause of this high white blood count is due to some kind of stress. And I think this is all.
That was awesome, Kiara. I feel like you synthesized all of the high yield teaching points from DKA from this case and at large in that nice little teaching section. So thank you so much for that. And I think that will be the end of the case for us all. Thank you again so much for joining us. To Drew and Sophia and Amanda for presenting, discussing, to Valeria and Kiara for scribing and teaching. That was a lot of fun. I hope everyone has a good rest of your day, and we will see you later on. All right, bye-bye.
Bye, guys.